Hello, this is Kamran Bhopal and I'm currently a urology registrar in the NHS and have recently gained a national training number. This is just a question session for raised PSA. I will be going over a few things or questions that I've got here in my book and what I've prepared. In my history, I did not talk about what initial investigations you would organize. So investigations for in the raised PSA station, if the patient has got LUTS with a raised PSA, usually you would go for an IPSS score, a bladder diary, flow rate, post-void residual, and urine dip and cultures, and then a renal function test, clotting profile in view of future biopsies. And then we can do specific prostate exam investigations, which includes a multiparametric MRI scan. And then usually this is discussed. I mean, at this point you can say what you do in your trust, but this can be discussed in the MRI meeting, or the patient can have a biopsy or be followed up in a prostate clinic to offer them biopsies according to the Likert or PIRAD scoring. If there's any systemic symptoms, we would request staging investigations, which include a CT chest and pelvis with contrast, as well as a bone scan. This is the textbook question, but you can also, if you just want to show that you've worked in urology before, you can say things like, if we saw any lymph node involvement on the MRI of the prostate, some trusts would go for a PSMA PET scan. And if there were bony lesions, we may consider MRI of the whole body as a staging scan. So this is something that can be said. The way you answer this question is very politely. Now, you're not going to make the decisions of a PSMA PET scan or an MRI whole body scan or whatever. You can make a decision if you're thinking metastatic disease and you want to start them on hormones. You can think about bone scan or CT chest or pelvis with contrast, just to confirm that this is metastatic disease. But as a registrar, usually this will go through your seniors. And you can just say, in my trust, if this happens, then we do this, so that it doesn't sound like you're confident to order these on your own or something like that. Sometimes we do actually, but that is usually based on trust guidelines. And if you're very familiar with the system, then we do it. And then, there's some important questions about how you would counsel the patient for prostate biopsies and the risks involved with it. I'm not going to go in that because you can look it up and you should know how to consent for a prostate biopsy and the risks involved with it. Oh yeah, there's a question about risk stratification. So previously we used to have the NICE risk stratification, which classified the prostate cancer into low, intermediate, and high risk. That was all based on the PSA, Gleason scoring, and T-stage. This has all changed now, so this is outdated. Don't say low, intermediate, high risk. The way they risk stratify prostate cancer now is the Cambridge prognostic group scoring. The Cambridge prognostic groups is 5 groups, and what they actually include is the group grade, the radiological, clinical, or histological stage, as well as the PSA. So 3 factors considered in this. The main difference is that they use the group grading. It is unlikely that they're going to ask this question because this is a very complicated and tricky question. So even if they ask it, if you start explaining what is CPG 1, 2, 3, 4, 5, it will be very difficult for you to remember, and you'll confuse yourself and the examiners, and it will take a huge amount of time even if you remember it by heart completely. So you have to find a definition to say, I know about the Cambridge prognostic groups, which classify it into 5 groups, 1, 2, 3, 4, and 5. And based on the group grade, PSA, and the T stage, we decide which CPG group they're placed in, which helps us with future management or future surgical management or offering them different treatments. So this is how you word it nicely. Then there's a question on watchful waiting and active surveillance. That's quite straightforward. Look up the FRCS Viva book. It's written quite clearly over there. Basically, watchful waiting is deferring palliative treatment, and active surveillance is that you're keeping an eye on the disease to let it reach a stage where surgical management becomes necessary. And the thing is, if you do surgical management or radical radiotherapy for prostate cancer without it being at that stage, it causes its own complications. So you can have overactive symptoms with the radiotherapy and bleeding, and then you can also have incontinence and erectile dysfunction if you do a prostatectomy. So to avoid those things, you keep an eye on things till it becomes necessary to actually do those procedures. Whereas watchful waiting is more just keep an eye on things, but we're only going to do anything if the patient becomes symptomatic. There is no radical treatment options for them in our mind, that they won't be fit enough for radical prostatectomy or radiotherapy. So we just wait and watch. If it spreads and it becomes symptomatic, then we can give them hormonal or systemic therapy as a maximum, or just keep an eye on things and symptomatically treat them. So that's your question. Then, okay, so treatment options for prostate cancer. There's active surveillance, then the surgical management, which is a radical prostatectomy. You've got radical radiotherapy, so these are radical options. And then you've got hormonal options, which is LHRH analogs, such as goziprelin with bicalutamide cover, or you've got GnRH antagonists, such as degarelix, in which you don't need any bicalutamide or androgen receptor blocker covers. We don't do bilateral orchidectomy in the NHS, it's very rare, and hence you can say that, but it's not necessary. If you want to show your knowledge, you could say that high intensity frequency ultrasound ablation is coming up as a new procedure for localized low-grade prostate cancers, but this is still in the trial process. Then the question they may ask is about the mechanism of androgen deprivation therapy. So this is the last question in the prostate cancer in my book. So androgen deprivation therapy drugs that I mentioned, there's two important ones, the mechanisms that you should know about. Okay, one of them are LHRH analogs, and one of them are GnRH antagonists. So these are opposite things. So how the LH releasing hormone analogs work? So they act on the pituitary and cause overproduction of LH, luteinizing hormone, which actually causes increased production of testosterone in the testes and causes increased DHT production, goes at the androgen receptors within the prostate cells and makes the prostate cancer grow. Now, you would think that LHRH analogs, you just told me something that has made things much worse by causing more secretion of LH, making more testosterone, making the prostate cancer grow. Yes, you're very right. But what this would do is this would burn out the pituitary. So much LH would be produced that this would completely burn out the pituitary to a point where the pituitary does not form LH anymore. And it takes about 2 weeks for it to burn out. And for that reason, to prevent this testosterone affecting the prostate cancer growth, we block the receptors at the level of the prostate cells, and that is your bicalutamide or the androgen receptor inhibitors. So when you're giving LHRH or luteinizing hormone releasing hormone, you're always giving bicalutamide cover or androgen receptor inhibitor cover, so that they can block at the level of the prostate cancer cells, so that even though the testosterone surge will occur, it will not affect or make the symptoms of prostate cancer worse. Then you've got your GnRH antagonists. What they do is they go and block the GnRH receptors at the level of the anterior pituitary and just stop the production of LH and FSH. So basically, you do not need anything such as bicalutamide to help with, blocking the testosterone surge, because there is no testosterone surge. The LH and FSH do not get released from the pituitary because of this blockade by GnRH antagonists. An example is degarelix. Degarelix is usually used in emergency conditions. It's very expensive, so you wouldn't be using it on everyone. That's why you would see most of people on LHRH analogs. Also, degarelix needs to be given once monthly as compared to the LHRH analogs, which need to be given once every 3 months. And so this degarelix is basically a very good one if, for example, someone's come with metastatic spinal cord compression, and we will go over it when we do the emergency scenarios. But someone comes with metastatic spinal cord compression, the thing that you can do is, number one, stop any further progression. So degarelix, in addition to obviously other things, you can give them steroids, and oncology may suggest palliative radiotherapy to the metastatic deposit at the spine and speak to the spinal surgeons about decompression surgery. We'll go over it when we come to the metastatic spinal cord compression station. But the mechanism should be clear in your mind that bicalutamide, which is an androgen receptor inhibitor, works at the level of the prostate cells and does not let dihydrotestosterone, which is the active form of testosterone, to attach to the prostate cells or prostate cancer cells, and doesn't let them grow. And henceforth, it is used in conjunction with an LHRH analog, whereas Degeralex, which is a GnRH antagonist, does not need any of that. This is how the mechanisms work for hormonal treatment in prostate cancer. I wish you the best of luck and hope all of you get a national training number and benefit from these videos. All the best. Take care.